Bismillah ar-Rahman ar-Rahim. Today I'm going to talk about the polycystic ovary or ovarian syndrome, the PCO, and its risk factor on diabetes. I'm going to start with the question, what is the most common endocrinopathy in a woman of reproductive age? Is it type 1 diabetes or type 2, hyperthyroidism, polycystic ovary syndrome, hypothyroidism secondary to Hashimoto, or hypothalamic amenorrhea? I know you all will choose the polycystic ovarian syndrome because this is the topic of my lecture, and that's right. It's the PCO syndrome. It's the most common endocrinopathy in women in the reproductive age. My agenda will be definition of the disease, etiology, pathogenesis, clinical presentations, diagnosis, and management. So what's PCO? PCO first described in 1935 by Stein and Leventhal. Those was the two doctors who described amenorrhea associated with bilateral polycystic ovaries. In 1935, in the 80s and 90s, addition of ultrasound criteria to the PCO. 2003, Rotterdam Consensus Conference. In 2018, there was international evidence-based guideline for the assessment and management of PCO in 2018. So the definition, it's one of the rising endocrine disorders affecting millions of reproductive age group females. It's called syndrome because it's had a multifactorial endocrine disorder. This syndrome is typically characterized by anovulatory cycles and infertility, altered gonadotropin levels, obesity, bulky multifollicular ovaries on the ultrasound. It's not only a disease which affects ovary, but may result in reproductive, male metabolic, and psychological consequences. It affects about from 5 to 10% of women are at reproductive age, making it the most common endocrine disorder in this age. From 10 women, there is one who suffer from polycystic ovarian disease. So, what is the etiology? What causes the PCO? Not clear 100%, still not clear. Many factors causing PCO may be genetic, maybe neuroendocrine, ovarian causes, teratogenesis, environmental causes, metabolic disorders, and food choices, physical inactivity, and others. So it's genetic disorders of androgen secretion, state of chronic hyperandrogenemia. It's really hotly debated at this point and not clear till now. The pathophysiology of the polycystic ovary. Is it insulin resistance? Yes, it's insulin resistant causing hyperandrogenism, and then hyperandrogenism causing insulin resistant, and we are going to enter a vicious circle causing both. So this is the tract of the gonadal hormones, the hypothalamus releasing the gonadotropin releasing hormone to stimulate the pituitary, which then secretes the LH and FSH, which stimulate the gonads to cause follicular maturation, and estrogen, progesterone, and testosterone to the uterus, causing negative feedback on the pituitary and hypothalamus by the inhibin. The insulin resistance in PCO is independent of obesity. Increased risk of impaired glucose tolerance and type 2 in PCO women. There is 30 to 40% prevalence of glucose intolerance, 7 to 10 prevalence of type 2 in patients with PCO, in women with PCO. So insulin resistance worsens over time. The AASD have already included the PCO as an important risk factor for diabetes and have recommended screening for diabetes by age of 30 in all patients with PCOs. So insulin resistance associated conditions was type 2 hypertension, atherosclerosis, dyslipidemia, impaired glucose tolerance, obesity, PCO, hyperuricemia, acanthosis nigricans, and others. High LH and hyperinsulinemia work synergistically, causing ovarian growth, androgen production, and ovarian cyst formation. That's how the PCO is formed. So, what's obesity? What's the role of obesity in PCO? Obesity approximately in 60% of cases. This is amplified the severity of the PCO presentation. Obesity is common, but not essential feature of PCO. The patient could be obese or not. Obese women with PCOs tend to be more insulin resistant than normal weight counterparts. The hormonal changes, the obesity exacerbates hormonal changes, so increases the androgens, the insulin, ovarian follicles and ovulation increase the estrogen, so the patient will suffer from menstrual disturbances, subfertility, androgens, increasing in androgen causing hirsutism and acne, increasing in the insulin causing the metabolic part of the disease, which is diabetes and metabolic syndrome, causing cardiovascular risk. So the patient also suffered from psychosocial issues, which is body image, self-esteem, depression, and anxiety. The clinical presentation of the patient suffering from PCO will be like hair loss, scalp hair loss, hirsutism, pelvic pain, infertility, overweight, irregular periods, fatigue, high testosterone level, and acne. So it's a common between polycystic ovaries, menstrual dysfunction, and hyperandrogenism. This is the syndrome. So first, hyperandrogenism causing anovulation and causing these polycystic ovaries. Hyperandrogenism will be in the form of hirsutism, acne, male pattern balding, or maldistribution of body hair. This is a picture of acanthosis nigricans in the back of the neck and in the elbow, in the axilla. Sterilization, which is usually mild in these kind of patients. If more severe, like clitoromegaly, deepening of the voice, increased muscle mass, we should at that time search for another underlying disease, which is an adrenal or pituitary gland disease, congenital adrenal hyperplasia, hyperprolactinemia, or androgen secreting tumors should be excluded first before saying this patient has PCO. Menstrual irregularities is common in patients with PCO. This is the picture of the above picture of normal hormones. Follicles can grow and ovulate, but women with PCOs no ovulation, so the ovaries are accumulated in the ovary. The patient will suffer from oligomenorrhea typically more than 35 days between cycle, only 4 to 9 periods per year. Occasionally menstruation cycle more normal, but menses are very light. Some PCOs don't menstruate at all. So we consider PCO if menstrual irregularities began at the menarche and continued after more than 1 year. We consider other diagnoses if these irregularities began years after puberty or suddenly worsened. So the pathogenesis of the PCO, it's due to an unopposed action of the estrogen, no progesterone. So this is lead to endometrial hyperplasia and consequently carcinoma and dysfunctional uterine bleeding. So this is a picture of the polycystic ovaries, the third part of the syndrome. Morphologically, ovary with 12 or more follicles measuring 2 to 9 millimeters in diameter, increased ovarian volume, a follicle usually peripherally located in the ovary. This is a picture in the ultrasound. It's called string or pearls. The metabolic changes of the PCO, which is very important in this case, the insulin resistance, the obesity, dyslipidemia, hyperandrogenism, and the hypertension. PCO causes that, and this is a very high risk factor for the subclinical cardiovascular disease and the clinical cardiovascular diseases. This is the symptoms that the patient is coming complaining of. It's the infertility is the most common, then the hirsutism, amenorrhea, then the obesity, then the dysfunctional uterine bleeding. So how to diagnose the polycystic ovarian syndrome? We're diagnosing by hyperandrogenism, ultrasound showing the polycystic ovary and the menstrual irregularities. The diagnostic criteria in 1990 was only menstrual hyperandrogenism, and exclusion of other etiologies. 2003, they introduced the ultrasound-guided polycystic ovaries showing the polycysts. Then in 2006, the same menstrual irregularities with or without ultrasound polycystic ovary. Hyperandrogenism is crucial, and exclusion of other etiologies. There are 4 different phenotypes of PCOs based on Rotterdam criteria. It's severe or frank. There is anovulation, hyperandrogenism, PCO. The classic is anovulation, hyperandrogenism only. No, there are no polycystic ovaries on ultrasound. Ovulatory, there is ovulation, but the patient suffers from hyperandrogenism and PCO. Non-hyperandrogenic, androgenic, which is the mild type, showing anovulation and PCO only, no hyperandrogenism. So what's the laboratory investigations done for this one to diagnose? We're going to diagnose the hyperandrogenism. We alter the LH and FSH levels, metabolic profile for the patient, and roll out the mimickers. First, we are going to measure the total testosterone level. The free is not reliable yet. It's the first line recommendation. Most values in PCOs less than 150. If more than 200, we should consider ovarian or adrenal tumors. We're going to measure the DHEA sulfate, most normal or slightly high in PCOs, but if it is raised above 800, consider please adrenal or search for adrenal tumors. The metabolic profile of the patient should be assessed, mainly the fasting blood glucose level and the 2 hours postprandial, and the stimulated test with oral glucose tolerance test may be more sensitive than the fasting measures. Lipid profile should be assessed because almost 70% of patients with PCO have an abnormal lipid profile, high triglycerides, low HDL, and high cholesterol and high low density lipoprotein. The clinical manifestations would be in the form of acne, acanthosis, hirsutism, obesity, infertility, hair loss, and irregular menses like pictures. So the management should be a multidisciplinary team between the gynecologist, dietitian, fertility specialist, physician or endocrinologist, and support groups. We should give the patient lifestyle changes, oral contraceptives and risk assessment, patient satisfaction with care. First, we're going to introduce oral contraceptive pills. The daily exposure to progestin, which harnesses the endometrial proliferation effect of estrogen, contraception in those not pursuing pregnancy, cutaneous benefits of the hyperandrogenic manifestations. But first, we have to exclude the presence of pregnancy. So the choice of oral contraceptive is 20 mg of ethyl estradiol combined with progestin, norethindrone, and norethindrone acetate. High doses of ethyl estradiol are needed in women, or transdermal or vaginal ring operations are potential options. Then metformin could be introduced in these patients. At first, metformin was having the upper hand because it treated oligomenorrhea. It's the second line therapy. If there is contraindication for the oral contraceptive pills, metformin will restore ovulatory menses in 50% of women with PCO. IVF pretreatment, metabolic is causing improvement in the plasma insulin and insulin sensitivity, reduction of the free testosterone, and it increases HDL cholesterol. This is a paper or study showing that metformin was less effective than an oral contraceptive in improving menstrual pattern and reducing the total testosterone concentration, but it's more effective in reducing the fasting insulin and the triglyceride concentrations. Management of androgen excess, like acne and hirsutism. There is a pharmacological therapy and direct hair removal methods like shaving, waxing, oral contraceptive pill and anti-androgen on 6 months to treat the hirsutism, but pregnancy should be obtained first before starting the oral contraceptives and the spironolactone. The drugs is available is spironolactone 50 to 100 twice daily. Testosterone acetate and finasteride, then dutasteride, and last frutamide. These are the anti-androgen drugs. Duration of drug therapy, a significant reduction in hair growth may occur for up to 6 months. Duration of administration of the drug. It is usually continued during the reproductive years, but when pregnancy is desired, all pharmacological treatment for hirsutism should be discontinued. Metabolic disorders should be addressed. Weight loss, it's first and crucial for all patients with PCO. Weight loss can restore ovulatory cycle, can improve metabolic risk using caloric restricted diets, combined with exercise, about 5 to 10% reduction in the body weight. No good evidence that one type of diet is superior to another. Maybe we should use bariatric surgery sometimes in morbid obese patients. We use metformin and thiazolidinediones, can reduce insulin levels in the woman with PCO. Limited data about patients using diet in greater weight loss than placebo. This is showing the studies, but needs more studies. The statins are effective only for dyslipidemia, but it doesn't work. It doesn't show effect in endocrinology or on the PCO. So finally, the polycystic syndrome, ovarian syndrome, it's a complex metabolic psychological condition, affects women's health and quality of life. Physicians should be aware of the clinical features and risks for women with PCOS and screen and manage accordingly. PCOS is the most common cause of hyperandrogenic chronic anovulation and infertility. Hyperandrogenism and hyperinsulinemia are the main keys in the development of PCOS. Obesity is a common feature of PCOS, but not a prerequisite for its development. Increased risk of developing type 2 diabetes and cardiovascular risk in patients with PCO. And thank you.